Hello, this is a epithelial tissue tutorial presented by the SchrDbb with reference Atlas of Histology with Function and Clinical Correlation by Dongmei Cui. So, epithelial tissue. So, we start with the first part of the tutorial, which is going to be the introduction. So, the epithelial tissue is a structure that is used to, it's a tissue that is used to cover other part of other tissues. It is used mainly for covering. So it is used to cover body surfaces. Now we have the other basic function of epithelial tissue. It is used in the protection of the body surface, like the skin and the oesophagus. It is used in the absorption of materials, like the epithelial tissue in the tubules, the renal tubules. It is used in the transportation of materials, like the epithelial tissue that is made up of cilia and that's on the trachea. It is used in the secretion of mucus and hormones. It is used in gas exchange, the gaseous exchange, like in the alveoli. It is used in lubrication. So now you have the classification of epithelial tissue. Generally, if you want to classify epithelial tissue, it is classified into simple epithelial tissue and stratified epithelial tissue. Now, the simple epithelial tissue and stratified epithelial tissue, you also have sometimes an additional one which can also be considered as a simple epithelial tissue, but usually not. It's called a pseudo-stratified epithelium. So you have simple epithelium, pseudo-stratified epithelium, and stratified epithelium. Now, the subclasses of the simple, pseudo-stratified, and the stratified epithelium is going to be based on the structure of the cell, which are located at the apical most part of this epithelium. The cells can either be flat, and when the cells are flat in shape, they are going to be called squamous. So when you hear the word squamous, you have cells which are flat. If the cell are cuboidal, if the cell have both like a cube shape that has both the width and the width and the height are the same, it's going to be said to be cuboidal. Columnar is said when you have a cell which is much more has a higher height and there's a lower than the width, so the height is greater than the width. They say that is columnar. So these are the three terms that you can be used. You can associate it with all this simple, stratified, and pseudo-stratified epithelium. So you can have a simple squamous epithelium. It means that when you say simple, it means that it's only having one cell layer. So that one cell layer is going to be directly connected to the basement membrane, because epithelial tissue is made up of two main things. You have the cell layer and you have the basement membrane. So those are the two main things that you have on epithelial tissue. Simple squamous epithelium, the cell layer is going to be flattened, that is squamous. And then simple, the cell layer, there's only one cell layer connected to the basement membrane. When you say simple cuboidal epithelium, you have now single layer of the cell layer, and then you have the cells in the cell layer is going to be cuboidal. It goes with columnar, also with pseudo-stratified. In pseudo-stratified, the point here is that they are not actually, they are falsely stratified. So in order for me to define pseudo-stratified, to say that it's falsely stratified, I'm going to first define stratified. So stratified is made up of a multiple layer of cells, and the lowermost cells, the lowermost cells are going to be attached to the basement membrane, while the apicalmost cells are going to be attached to the lumen, or lumen if it's a mucous membrane, or you are going to have the skin and the exterior. Now the stratified squamous epithelium. Stratified squamous epithelium, it means that the apicalmost, it is made up of multiple cell layer, and the apicalmost cells are going to be flat shape. The stratified cuboidal epithelium is made up of multiple layer, usually 3 cell layer, and the apicalmost cells are cuboidal. In stratified columnar epithelium, it is made up of multiple layer, and the apicalmost cells are columnar. So these are the different things that you have to know. Why now in pseudo-stratified? Yeah, the problem here is that the cells have different height. So we have different cells have different heights. So one is tall, one is short, one is tall, one is short. It makes, and those different height, it also have different position of their nucleus. So since they have different height or different position of their nucleus, one has a tendency when visualizing on the microscope to say that it is stratified, that has multiple layer, while it is not. It is having a single layer, but that single layer of cell is made up of cells that have different height and different position of their nucleus. That make it seem like if it is stratified, so thus the name, it is pseudo stratified. Now the next thing is that we're going to visualize the other epithelium type. So the other epithelium type, we have the transitional epithelium. Transitional epithelium is much more going to be found in the urinary tract, and this transitional epithelium, it is going to have different shape depending on where the content of the material of the urinary tract. So it is expansile. So the transitional epithelium, when they are relaxed, the apical muscle are dome shape when they are relaxed, or umbrella shape. While when there is a content inside the urinary tract, they are going to be flattened. So it means that they are much more expansile, changing shape. Now we have the next one. Now, specialization of the apical surface. So the specialization of the apical surface, you need to know that what we have, the cilia, which is located at the apical surface, and the cilia is made up of we said microtubules, and the inferior most part of the cilium is made up of the basal body. Then the second one that we have at the apical most part is the microvilli. The microvilli, it is used, cilia is used for motion, for movement of the different part elements which are located above the cell, and microvilli is used to increase surface area for the reabsorption of material. And this microvilli is made up of the actin myofilament, the actin microfilament, and they are located, and the inferior most part of those microfilaments of actin are how you have attachment to the terminal web. Then the third thing is the stereocilia. The stereocilia is still made up of actin filament, because the stereocilia is like the microvilli. It is just simply termed a long microvilli. It's a stereocilia. So this is the specialization of the apical surface of the epithelium. Now, the specialization of the lateral surface of the epithelium, you need to know what these are much more what attaches. At the lateral part of the epithelium, you have attachment to the other epithelial cells, because you need to know that what epithelial cell has no blood vessel in it. Epithelial tissue has no blood vessel that passes in it. So, if the blood vessel is located at 10 meters away from an epithelial cell, all the movement is going to occur by diffusion, osmosis, and all the other passive transport you know. So no movement occurs directly between the blood vessel and the epithelial cell. Mostly all the movement of the material into the epithelial cells is by active movement. That's why there's a need of a connection between the specialized of the epithelial cells. Now the connection can be, the first one, you have the tight junction. So the tight junction is also called the zonular occludens. So you have the tight junction. The second connection is by the adherent junction. The third connection is by the desmosome. The fourth connection is by the gap junction. And the gap junction is the one that is used in connecting the materials. So there is a connect zone, that is a hollow-like tube that connects the two epithelial cells, and that the hollow-like tube is used in communicating materials from one cell to another, since they are mostly flowing by a passive transport method. Now the next thing to visualize now is specialization of the basal surface. Now at the basal surface, we have what is called the basement membrane. The basement membrane can just be seen on the light microscope, but in order to really appreciate the basement membrane, we are going to use an electron microscope. And on the electron microscope, you can visualize now the basal lamina and the reticular lamina. The basal lamina is directly connected to the cell, while the reticular lamina is inferior to the basal lamina. Okay, so these are the different things that we wanted to know. And now the cell is connected, the epithelial cell is connected directly to the basement membrane by using now the hemidesmosome. So now these are the structures of these different cells. So when you are said to be squamous, you are flat shape and your nucleus is elongated, as you can see here. When you are said to be so squamous has a longer width than the height, flattened. Cuboidal, it has a height and the width are comparable, and then their nucleus is spherical. So columnar, the height is greater than the width, and then they have elongated nucleus. Then pseudostratified, as you can see, pseudostratified, you have one cell which is tall, one cell which is short, and the nucleus have the different dimensions. As you can see here on the light microscope, you have tendency of saying that this is one cell layer down here. You have a tendency to say that this is another cell layer up here, as you can see. So this is why you can see you can see that it is stratified, but they are not actually stratified, because if you see the lowermost part of this cell and the uppermost part of this cell, you see that the cilium is just having, so all the cytoplasm is connected with only one cell, so it's not multiple cells that have those cytoplasm. Are you seeing? So that is why it is said to be pseudostratified. Now in stratified epithelium, we can be squamous. So in stratified squamous epithelium, the uppermost part here is having flattened cells. As you can, this is a diagrammatic representation, this is a microscopic representation, flattened cells. Now this squamous epithelium, you need to know that squamous epithelium is divided into two. It can either be keratinized or non-keratinized. In keratinized, you see here that there is a flattened cell above here, and the flattened cells above here don't have any nucleus. So they are dead cells and they don't have any nucleus. When they don't have any nucleus here, just know that it is keratinized. And they are also eosinophilic, which means that they are pink. They are absorbing eosin. So that is stratified. That's keratinized stratified squamous epithelium. Now in non-keratinized stratified squamous epithelium, you have the uppermost cells are flattened and they have a nucleus. They are not dead cells. Is it clear? That's compared to this keratinized. Now for cuboidal stratified epithelium, we have 2 or 3 layers, usually 2 or 3 layers, and the lowermost layer is cuboidal, the uppermost layer is cuboidal. For stratified columnar epithelium, usually 2 or 3 layers. The lowermost structure, the cell layer is going to be cuboidal, and the uppermost cell layer is going to be columnar. And then the transitional, here you have the uppermost layer is going to be, as you can see, it's going to be dome shaped. So this is just a brief view of what you have seen already. So we now start with the direct visualization. We just explain directly what is the different epithelial type. So we start with simple squamous epithelium. So for simple squamous epithelium, at the inferiormost part here is the mesothelium. So you already know what's the mesothelium. So let me just give you what's the meaning of mesothelium. The mesothelium is just a simple squamous epithelium. That line is serous cavity. And those serous membranes, example of serous membranes are the peritoneum, the pleura, and then the pericardium. That's a mesothelium. So do you see the mesothelium is going to be located both between the visceral, this is the visceral part, and this is the parietal part here. So we have the mesothelium, and then in this insert we are going to have mesothelial cells, and those mesothelial cells are flattened cells which are epithelial cells. Also at the lumen you also have epithelial cells here. Now the clinical correlation is that excessive secretion by the mesothelial cell is going to be in a pleural cavity, is going to produce pleural effusion. If there is some inflammation of the mesothelial cell in the pleural cavity, it's going to be called pleurisy. Inflammation in the peritoneum is going to be called peritonitis, and inflammation in the pericardium is going to be called pericarditis. So this is the mesothelial cells. So you see inferiorly the connective tissue and then the basement membrane. Then down the clinical coloration is mesothelioma. So what is mesothelioma? Mesothelioma is just a cancer of the mesothelium for clinical coloration, and it's usually located on the pleural and the peritoneal cavity, usually less found in the pericardial cavity. Now, the mesothelioma is usually occurring in patients. So the risk factors of mesothelioma is in patients that have been smoking, that has been having occupational, or you can have a occupational disease. People that have been exposed to asbestos or silicosis, mostly asbestosis. So that is why they are going to have. Now, you have a microscopic view of the mesothelioma. So the microscopic view of the mesothelioma is that what you're going to visualize microvilli at the level of the uppermost part. Normally the mesothelium do not have microvilli, but you see malformed cells and then you see microvilli, and so this make you think of a mesothelioma. Are you getting? And then the last thing is that the mesothelium have a high spread. They can easily spread from their original site and all that. So this is, and the common root of the spread is the lymphatic system. So this is the next view. See, this is for the simple squamous epithelium. The simple squamous epithelium taken from blood vessels. So with simple squamous epithelium, the uppermost part we still have flattened cells, and then the lowermost part we have the basal cells, and the basal cells are capable of regenerating and coming back. Now, the clinical correlation of simple squamous epithelium in the blood vessels is that you can have atherosclerosis. Atherosclerosis is just a deposition of yellowish material underneath between the tunica intima and the tunica media. The tunica intima is the innermost part of the blood vessel, while the tunica media is the middle part of the blood vessel. So there can be accumulation of the fatty structures there. So because if in case where a patient has dyslipidemia, a patient has diabetes, or a patient has hypertension, there can be accumulation. The very light density lipoprotein can come and accumulate here, and when very light density lipoprotein come and accumulate here due to an endothelial injury. Hypertension can cause an endothelial injury. See here that there is an opening here. So the foam cell macrophages can enter here and try to digest those material, fatty material in between, and when they digest those fatty material, they produce foam cell and they cannot degrade. That's why they are going to produce plaques, and in order to control those plaques, the smooth muscles around are going to contract in order to make sure that those plaques are not dislodged and produce an embolism. So this is now the ultrastructure of the cells. So here is going to be the lumen of the blood vessel, and here is the lumen of a thin segment. So here you have a squamous cell here. You see it is flattened. At the inferiormost part of the squamous cell you have the nucleus here. So now we have the next part now with the simple columnar. But before we continue, I will just give you, at the end of all this, I'm going to give you the locations of different epithelium in the different part of the body. So here we are just describing the structure. So for the simple cuboidal epithelium, we've said for the diagrammatic representation is like this. So we have a single layer, and then all the cells are cuboidal. So in that single layer, all the cells are cuboidal. Example of location where you have simple cuboidal epithelium is going to be the thyroid gland. So you see in this case you have the cuboidal epithelium, which are going to be lining the different colloids. So this is the colloid which make up the thyroid gland, and those colloid now. So this simple cuboidal epithelium are used in the secretion of tyrosine and the production of the thyroid. They are used in the secretion of thyroglobulins into the colloid and the production of tyrosine, and tyrosine is going to bind to those thyroglobulins in order for it to be stored inside the thyroid gland. So this is just a diagrammatic representation of that. Now, since tyrosine is a protein, that's why you are going to have many rough endoplasmic reticulum inside the simple cuboidal epithelium of the thyroid gland. So the clinical correlation is the hyperthyroidism. Hyperthyroidism is just characterized as a clinical condition where you have excessive thyroid hormones, and a very good typical case of hyperthyroidism occur in women as Graves' disease. And Graves' disease is a triad of goiter, so it's a triad of hyperthyroidism plus pretibial myxedema plus exophthalmos. Now, the clinical correlation of that with histology is that in hyperthyroidism, the cells of the cuboidal cell become columnar cells. When you see the dissection, the cuboidal cells change from cuboidal to columnar in hyperthyroidism, while hypothyroidism, they change from cuboidal to flattened cells, as you can see here, to squamous cells. That's clinical correlation. Now, the next thing to visualize is the simple cuboidal epithelium. Another part where you can see simple cuboidal epithelium is going to be the kidney, the tubules of the kidney. So as you can see here, we have tubules, and what is lining those tubules here, this is of the collecting duct, and this is the proximal convoluted tubules. So in both of them, we have cuboidal epithelium, and those cuboidal epithelium have microvilli at the apical most part, and they have many ATP producing structures like the mitochondrion. So since they have many, as you can see, if you go back to cytology, you see that the renal tubules have many mitochondria to produce ATP for the reabsorption of these materials. So when they are going to reabsorb these materials, now they can be recirculated into the system. So this is just the visualization. You see that at the apical most part, you have many microvilli for the reabsorption, and then it's cuboidal cells. So when you have cuboidal cells plus microvilli, it can make you think of the renal tubule cell part. So that is it. So at the base, you have basement membrane and connective tissue. So now the clinical correlation now with this is now the Fanconi syndrome. So Fanconi syndrome is the impairment of the proximal convoluted tubule to the function, resulting to abnormal epithelial lining. So in this is a genetic disorder, and it can also be have also environmental factors associated with it. So it results to a substance that should be, so the substance that normally should be absorbed in the bloodstream are not reabsorbed. Example, you have glucose, you have amino acids, you have phosphate, you have bicarbonate, and you have calcium are not reabsorbed. Since they are not reabsorbed, all of them are going to be secreted into their urine, and then the patient may have rickets. And this form of rickets or osteomalacia is not because the patient is not taking a vitamin D or the patient not taking enough calcium, but instead because he's losing calcium inside his urine involuntarily. So now, how do you visualize now Fanconi syndrome now on a histology? So to visualize Fanconi syndrome histology, you are going to have cells. The cells are the cuboid. Normally the proximal convoluted tubular cells are going to be cuboidal in shape, but you see that the cells are going to be much more squamous cells. So when you have cells which are much more squamous than cuboidal, that is first thing. The nucleus, normally the nucleus is going to be spherical, but the nucleus here in Fanconi syndrome, they are going to be distorted. The basement membrane if the basement membrane becomes wrinkled, as you can see here, you see wrinkled basement membrane, as you can see, or you can thickened basement membrane, you see that it is Fanconi syndrome. And the last one is that the microvilli are reduced in number and length. So here you have much microvilli and the length is longer, while here the microvilli is shorter and then they are smaller in number. So it can make you think of Fanconi syndrome based on the histology. So now the next thing is the simple columnar epithelium of the gut, small intestine. So as you can see here, you have the simple columnar epithelium all through. This is the villi here of the small intestine. This is simple columnar epithelium above here. So these cells here, which have whitish appearance here, are the goblet cells. These cells here with these whitish are the goblet cells, and these are the secretory vesicles which are there containing mucins. So now these cells, the diagrammatic representation of the cells of they call simple columnar epithelium is that they are much more columnar. They have microvilli. The inferior part of the microvilli is the terminal web, as you can see here. Now you see this the clinical correlation of the simple columnar epithelium of the small intestine is the celiac disease. And what is celiac disease? Celiac disease is just an gluten intolerance where you have hypersensitivity reaction to gluten. So here you are going to have destruction of the villus of the villus of the small intestine and all that. Now, how is it this celiac disease seen on the histology? So when you ask for histology and you see celiac disease, you are going to have blunting of the villi. Blunting of the villi is just because of the destruction of the villi. You are going to have blunting of the villi. The villi disappear. 1. 2, you have the presence of lymphocytes inside the epithelial cells. Normally, you should not see lymphocytes at the junction of the epithelial cells. But when you start seeing lymphocyte junction of epithelial cells, zonal occludence, adherence like that, you think of celiac disease. The next thing is that's called intraepithelial lymphocyte. The third thing is the increased lymphocyte within the lamina propria. The lamina propria is just beneath the mucosa of the small intestine. So when you see large number of lymphocytes within the lamina propria, you can also think of that. So those are the elements. Also the microvilli, there's a loss of microvilli. So first thing is loss of microvilli. We have disruption of the terminal web. You have the columnar cells. So these are the columnar cells here. The lymphocyte, you see intraepithelial lymphocyte, and then you see also much more increased lymphocyte inside the lamina propria. Those are the elements which are favorable for celiac disease on the histology. Now this is just going to be the specialization of the cell surface. So specialization of the lateral part of the cell, you have avoided this. First one is the zonular occludence. So the zonular occludence is made up of intramembranous proteins. So those are called the sealing strands. So you can see it here, zonular occludence. The second one is the zonular occludence is located at the apical most part, just inferior to the zonular occludence. You have the adhering junction, the zonular adherence. The zonular adherence is going to be attached now to the actin filaments, and then in between the actin filaments you have the transmembrane linked proteins, and you also have the intracellular linked proteins. So these are the things that you have for the zonular adherence. The next one is the desmosome. So for the desmosome, here you are going to have an intracellular attachment plaque at the part of the cell. Inside the cell, the intracellular attachment plaque is going to be attached to the intermediate filaments inside the cell, and then outside the cell, the intracellular attachment plaque is going to be attached by the transmembrane proteins, and that transmembrane protein is just similar like a zonular adherence. That's why zonular adherence is having a similar name with desmosome, that is a macular adherence. Now the next one is a gap junction. The gap junction, you have the proteins connecting it are hollow structures, so you make sure that there is a connection between the two epithelial cells. As I've already told you, the only method of transportation between epithelial cells is going to be by passive transportation. So there is no blood vessels in the epithelial cells, though they may be stratified and multiple cell layer. It means that all the cell layer is going to have its material just by passive transportation. So in order to make sure that this occurs, there is a gap junction. That's a hollow-like proteins that connect between the different cells. Then the next one is the hemidesmosomes. The hemidesmosomes is just like the desmosome. You have the plaque here. This is the intracellular plaque attached at the uppermost part. In the intracellular part of the plate is going to attach to the intermediate filament. Now the hemidesmosome attaches the cell to the basement membrane, and I've already said that the basement membrane is divided into two, which is the basal lamina and the reticular lamina. The reticular lamina is going to attach the basement membrane to the connective tissue underneath, while the basal lamina is going to attach the basement membrane to the cell. Now the basal lamina is divided into two. It's divided into the lamina lucida, which is much more closer to the cell, and we have the lamina densa, which is much more closer to the reticular lamina. Now we continue now with the pseudo-stratified columnar epithelium. So this is pseudo-stratified columnar epithelium found inside the trachea. So for pseudo-stratified columnar epithelium, the particularity of the pseudo-stratified columnar epithelium is that it's going to contain cilia above it. The cilia are located above it like that. So you can see here you have nucleus. The nucleus, you have multiple layers of nucleus. This is one lower layer of the nucleus. This is an above another layer of the nucleus. So it may make you think of a stratified squamous epithelium, but this is not a stratified squamous epithelium, because if you increase the magnification, like you can see here, you see that all the cytoplasm is connected with the lowermost part of the cell. Is it clear? So that is the pseudo-stratified columnar epithelium. So now in the pseudo-stratified columnar epithelium, so these are the cilia. This is diagrammatic representation. You have the cilia at the inferiormost part of the cilia, at the apex there you have the basal bodies. I've already said that. Then in between the pseudo-stratified, you have also the goblet cells, and the goblet cells is going to produce mucin, or in this case we are located inside the trachea. It is going to produce mucin in order to make sure that the trachea is always lubricated, or the respiratory tract is lubricated. Then you have the basal cells at the inferiormost part, which is used in the production of all these other cells in the pseudo-stratified epithelium. Then you have the connective tissue and the basement membrane. So this is the basal body, which is connected to the different microtubules of the cilia, as you can see here. Now the next thing is a clinical correlation. So clinical correlation of pseudo-stratified epithelium is bronchitis. Bronchitis is just chronic inflammation of the bronchial tree. That's bronchitis. When you have chronic inflammation, when you have just inflammation of the bronchial tree, it's going to be bronchitis. It can be either chronic bronchitis, that's chronic inflammation of the bronchial tree. It can be acute bronchitis, acute inflammation of the bronchial tree. And this chronic bronchitis mostly occur because of cigarette smoking. And now, how do you visualize chronic bronchitis on a histology, on a histopathology? So in chronic bronchitis, you are going to have cell surface of the epithelium may become a hyperplasia. So may undergo hyperplasia, and you have loss of cilia. It means that what? It means that the cells are going to be increase in the cell surface, increase. You have hyperplasia or just metaplasia. Metaplasia is a term that is best to say this. So you have hyperplasia, metaplasia. So you have it can become hyperplastic, meaning that the cell number is going to increase. One. The second thing is that in chronic bronchitis you may have loss of cilia. So the cilia is going to reduce, loss of cilia, the pseudo-stratified epithelium, and then you also have a squamous metaplasia. So those are the three main elements that you see in chronic bronchitis. Hyperplasia, so hyperplastic columnar cell means that what? Means that the cells increase in number. The first thing. Second thing, you have metaplasia. Metaplasia, here you see that what? Normally here you only have one cell layer, but it's the cell layer, when you have now two cell layer with the apical most cells being flattened, that's called a squamous metaplasia. Normally in the pseudo-stratified epithelium of the trachea, it is supposed to be one cell layer. But now when it converts and become a multiple cell layer, that is, it becomes now a stratified squamous epithelium, that's going to be called a squamous metaplasia. Now another thing that you can visualize in chronic bronchitis, since it's an inflammatory process, you may have inflammatory cells as lymphocytes located inside here. So inflammatory cells located in the connective tissue. So we have mucus, loss of cilia, we have the loss of the basal body, you have hyperplastic columnar cells, you have squamous metaplasia, and you have inflammatory cells in the connective tissue. That's how you recognize chronic bronchitis on a histopathology. So the next thing here, this is just the ultrastructure of the same thing that you have seen above here. So these are the goblet cells with the secretory vesicles here. You are going to have the columnar cells. These are the pseudo-stratified columnar cells located here with the cilia above it. So the next thing are the apical specialization of epithelium. I've already seen that. I've already said that the cilia is, so you can see, so you have the cilia, you have the microvilli, and you have the stereocilia. So the difference is that what the cilia is 0.2 micrometer in diameter. And then it is 5 to 10 micrometer long. So that's the length of the cilia. The second thing is that the cilia is made up of a core called the axoneme, and the core of the cilia is made up of the microtubules, and the microtubules is made up of pairs. So inside the core of the cilia, that's the axoneme of the cilia, you have pairs of microtubules. So that is, we have 9 pairs of microtubules. That's generally called 9 doublets of microtubules. It's called 9 doublets of microtubules, and those microtubules are made up of proteins called D9. And then at the inferiormost part of the microtubules of the cilia, we have attachment down to the basal body. Now for the microvilli, it is 0.08 micrometers in diameter and it is 1 micrometer long. It is made up of actin filaments. Is it clear? So at the inferiormost part of the actin filament, now you have the terminal web. I've already defined that. The next one is the stereocilia. The stereocilia is just defined as a long microvilli. It is 0.1 micrometer in diameter and it is up to 10 micrometer long, just like a cilia. So if you see a very strong long structure, but which is not used in motility but in reabsorption, just think of a stereocilia. It's not actually a cilia, it's a stereocilia. So this is where you can see it. So you see 1, 2, 3, 4, 5, 6, 7, 8, 9. These are the 9 doublets which are located around, and then you have a central microtubules, the 9 doublets of microtubules here in the cilia, and then a central microtubule. Is it clear? So that is it. So this is just the core of the cilia, and that core of the cilia is going to be called the axoneme. So it is called a 9+2 arrangement. There are 9 doublets at the periphery and the central microtubule. Now for the microvilli, we have it's an irregular arrangement of the microtubule. The microtubule, the actin filament are just parallelly located just parallel, and then at the inferiormost part of the microtubule of the actin filament, you are going to have the terminal web. Then the next thing to visualize today is going to be the stratified squamous epithelium. So for the stratified squamous epithelium, in this case, is going to be keratinized. So when it is keratinized, you need to know that what the inferiormost cell layer is going to be the basal layer, and then the uppermost cell layer, here you visualize that what here it is granulated. You have cells here, you have cells that are having nucleus, but at this uppermost layer the cells are still flattened, but there is no nucleus here. So this is why it is keratinized, and this one is located on the skin, on thick skin, like in the palms of the surface of the palms of the hand. Is it clear? So this layer is the layer of the stratified squamous epithelium. At the uppermost layer here you have dead cells with keratin. Is it clear? So this is the diagrammatic representation. So just here you have the basal layer, the basement membrane. You have the basal layer, that's stratum basale. Then you have the stratum spinosum. The stratum spinosum is made up of pentagonal or hexagonal cells. Then you have the stratum granulosum. The stratum granulosum is made up of with pigments here, pigmented cells. Yeah, dark pigmented cells here, that's stratum granulosum. Then you have the stratum corneum just above the stratum granulosum, and the last one is the stratum so you have the stratum lucidum first, just above the stratum granulosum, and then the last one is the stratum corneum that contains most of the keratinized cells, and then they are mostly dead cells. Then the clinical precoloration of stratified squamous epithelium on the skin is psoriasis. What is psoriasis? Psoriasis is a common chronic inflammatory skin disease characterized by pink color or salmon colored plaques. So we have plaques is just a skin rash which is raised with a flat top and greater than 1 centimeter. So if you have a rash that is greater than 1 centimeter raised with a flat top, that's a plaque which is pink, and silver scales, so also scales on the body with sharp margins. So it is due to chronic inflammation. Just know that it is psoriasis, and it is due to a T lymphocyte mediated inflammatory response. That's a type 4 hypersensitivity. Now, how do you visualize psoriasis now on the clinical picture? So you have parakeratotic scales. So actually, what are you going to see? You are going to see parakeratotic scales on the histology. So you have parakeratotic scales on histology. You can see micro abscess. So see micro abscesses. So the difference between an abscess and a pustule is that an abscess is greater than 1 centimeter, and a pustule is a pus containing structures which is less than 1 centimeter. You can have micro abscess still on the histology. You have micro pustules still on the histology. You have inflammatory connective tissue, and you have dilated capillaries. So that is those are the elements on the histopathology. So when you just take a biopsy, those are the different things that you can visualize. So on the stratum corneum, can start with stratum corneum. In the stratum corneum, you're going to see parakeratotic scales, and you can see micro abscesses. In the stratum granulosum, there is micro pustules, and you can see. With the stratum spinosum, also the micro pustules you can see. And then the last one is the stratum basale. You're going to have inflammatory connective tissue and the dilated connective tissue. All that is what you're going to see in psoriasis. Now we have stratified squamous epithelium now, which is non-keratinized. In this case, we have seen it in the esophagus. So this is the stratum. So we see the apicalmost layer is going to still be flattened, and then the cell made of a squamous epithelium. So as you can see now, the inferior most that the basal cells are much more cuboidal in shape. Then here is hexagonal in shape. Then you have squamous cell shape located. So it is just made up of 3 main cell layer. Mostly when you are inside the non-keratinized, mostly made up of 3 main cell layer. And those cells, stratum basale, stratum spinosum, and stratum superficialis. Those are the 3 main cell layer that you have. And the stratum superficialis is made up of the squamous cells. Now, you have the clinical correlation is Barrett esophagus. So in Barrett esophagus, it's a complication of a chronic gastroesophageal reflux disease. So here in Barrett esophagus, it's just a metaplasia. So when you have metaplasia of the stratified squamous epithelium, normally located inside the esophagus, now to a simple columnar epithelium, is going to be called Barrett esophagus, and it is a high risk factor for developing an adenocarcinoma of the esophagus. So how do you visualize that stratified metaplasia? It is converting from stratified squamous epithelium, normal stratified squamous epithelium of the esophagus, to a simple columnar epithelium of the stomach, in order to adapt to the condition of the stomach due to a chronic gastro reflux. So when the gastric juice is going to reflux inside the esophagus. So how do you visualize it on the histology? So to visualize on histology, you're going to have metaplastic columnar cells. Normally the cells are supposed to be multiple cell layer inside the esophagus, but here you have metaplastic, means you have only 1 cell layer, and you also have goblet cells which are seen. Is it clear? So from here it marks the end of our tutorial. Thanks for your kind attention.